bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities.
Hello, everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. It's great to be back as our second webinar of the new year, and today's webinar is titled Picturing Wellness, Art, Innovations, and Knowledge Exchange, and this is coming from the CIHR Team grant on sexual victimization in boys and men's health. All right, so on with the presentation. It is once again my pleasure to welcome back some of our colleagues that we're connected to through the CYCC network. That's the Children and Youth in Challenging Contexts network. The CYCC network uses knowledge mobilization strategies to improve the mental health and well-being of children and youth living in challenging contexts. Lots of innovative and creative stuff happening over there, and you can always get lots more information about what they're doing at www.cyccnetwork.org. So it's always great to partner with them to bring interesting content. So now it's my pleasure to introduce today's panel, but before we get to that, before I introduce our panel, we're just going to do a quick poll just to see what our audience is thinking right now. So the question is, when picturing wellness, what do you think has the greatest impact on wellness? Is it social ties, inner grit, a combination of various inner and external resources, or physical practices such as yoga or meditation or that sort of thing? What do you think? Has the most impact on wellness? All right, we'll close that poll, and we're going to come back to the results of that later on in the session. All right, so now it's my pleasure to introduce today's panel, or speakers, I guess, not really a panel since there's only two of them. First up, we'll have Dr. Christine Weckerle, who is a clinical psychologist and an associate professor in pediatrics and an associate member of the Offord Centre for Child Studies at McMaster University in Hamilton. Dr. Weckerle's research areas are broadly in the areas of parenting and the prevention of family violence. Dr. Weckerle has presented a few times on our CAFC Presents webinars, and you can certainly find any of those previous ones just by searching for her name on the Knowledge Exchange Network. She's also presented at the CAFC conference in the past, so it's great to welcome her back. And joining Chris is Margaret Schimba. She has a background in the history of medicine and healthcare, gender and interdisciplinary health education. She's a regular columnist with the Hamilton Spectator, writing on social and political issues, and she is a partner in the Picturing Wellness initiative. So it's my pleasure to hand the virtual podium over to Dr. Weckerle.
Okay, hi, and welcome to everyone, all you happy CAPC webinar people, and hope you're doing well today. And as you may notice, I have a cold, so I'm sorry if there's a bit of stuffiness to the voice, but we'll carry forward. So we're coming from a base of a CIHR funding with the Institute of Gender and Health and the Public Health Agency of Canada on a team grant that really has the wonderful opportunity of looking at an underattended area, and that is the sexual victimization of male youth, whether that is child sexual abuse or adolescent dating violence or sexual exploitation and street-involved youth. We're looking at that whole kind of range of information, trying to really grapple with what's going on in terms of experiences, but also the disclosure process. And we know that males do not go to help seeking as often as females, so we're wanting to influence that help seeking process as well. And a big focus not only is in health outcomes, but resilience. Resilience is really that bridge variable that can carry you from a history of maltreatment into a life of that's worth living, of functionality in the various domains we look to. And so a lot of the discussion today will be around resilience. And with this focus on resilience, we've crafted an initiative that has many components on picturing wellness. And do look to the Child Abuse and Neglect Journal for some upcoming special issues in resilience. And currently at McMaster Museum of Art, we've co-curated a exhibit that looks at violence against women, child maltreatment, adverse contexts, and resilience in these. So it's a wonderful interdisciplinary opportunity to engage with community resilience that a museum can offer. So now we'd just like to flesh out this idea of the science of resilience for you with a video that features some primary researchers in development, child development, and resilience. So we'll go to the video.
A short video here, and we apologize if we have any technical issues, but we'll do our best to get this going.
Yeah, I wanted to give you an opportunity to have some sort of sense of who else is in the field working in this, and sort of the high interest materials that are available that you can use.
And this was the TEDx one or the other one?
The other one.
The other one. In brief.
And the key message of this upcoming video is really to think about that ratio of negative experiences to positive experiences, and wanting to make sure that the ratio is much higher in positive experiences. Others have found kind of a 5-to-1 ratio as being important. But
resilience is the result of a highly interactive process between individual characteristics in the person and the environment in which that individual has developed.
It's really the counterbalancing of difficult things that may exist in the child's life with positive things that occur within the family, but even positive things that may exist in the community.
An easy way of thinking about resilience is like a scale with a fulcrum in the middle of it. And there are things on both sides of that scale, experiences of both bad things or good things.
Our genes shape where the fulcrum is positioned at the start.
There are certain genes that make a child more sensitive to the effects of maltreatment or parental neglect or witnessing violence.
The fulcrum may start out kind of more towards one side or more towards the other side, and that's going to make a big difference in terms of how much these subsequent events affect things positively or negatively.
Science tells us that experience moves the fulcrum, for better or for worse.
Even though we are born with genes, genes will respond differently to certain environmental situations as opposed to others.
What the genes are actually doing are turning up or turning down the expression of chemicals in circuits in the brain and the circuitry in the entire body that govern our responses to stress, to anxiety, to depressive symptoms.
When positive experiences accumulate and children learn coping skills that help them to manage stress, the fulcrum can slide, so the scale tilts toward positive outcomes more easily. That's what resilience is all about.
There's always an adult, or more than one adult, who is key to providing that relationship that helps to build resilience.
right, so I'm going to turn the speaking function over to Margaret Skimba, who's going to talk about this Picturing Wellness Conference, another opportunity for individuals to up their own professional resilience by learning more about resilience. Here's Margaret.
Hi, everybody. Thanks for coming today, or going online, tuning in. I just wanted to talk about the Picturing Wellness from Adversity to Resilience art exhibition and conference that we've planned in sort of conjunction with Christine's work here. The 3-day conference is designed to share the state of the science on male childhood treatment, particularly sexual assault, that's come out of the CIHR grant, that team grant that Christine's been working on. And our audience, of course, is healthcare and service providers working in the area of male sexual assault. And we do have accreditation for physicians who are looking for that accreditation piece. Special guest that we've got coming is Sheldon Kennedy, who is most people know who he is, the ex-NHL player and child abuse advocate. We've got Project TEAR, Teams Ending Abusive Relationships from Victim Services Toronto. And Harrison Wheeler, who is a Hamilton-based mental health advocate and performer, will be putting on his one-man show, Gestures Incognito. The topics that we'll be covering cover a wide range of topics. Under different themes, we'll be looking at resilience in relationships, art as a resilience strategy, sexually exploited youth wellness, child sexual abuse among male youth, and violence prevention as a resilience strategy. And we've got really great speakers coming. We've got Dr. Christopher Mushquash, who is the Canada Research Chair in Indigenous Mental Health and Addiction, who will be talking on Indigenous youth. Dr. Harriet McMillan, who is a leader in the field of child abuse, will be speaking on how to prevent state of the science in child abuse and how to prevent and identify. We'll also be looking at ways to use art in terms of teaching healthcare, or what healthcare workers can learn from art. And we've got people from the Stigma and Resilience Among Vulnerable Youth Center coming to talk about resilience among sexually exploited youth and interventions to foster resilience among sexually exploited youth. If you want to find out more about the conference, I've got the conference website up there. It's got the whole program outline up there and how you can register. Early bird registration ends January 30th. So if you want to get in there on early bird, you've got till January 30th to do that. So if you have any questions, you can reach me through the Picturing Wellness website. And I'll turn this over to Christine now.
Hi again, everyone, and both Margaret and myself are active on Twitter, and you can connect with us and find more about the conference off of Twitter. And my Twitter is at Dr. Weckerly, and Margaret's Twitter is at Minerva Sophia. And we welcome you to join in this conversation for Picturing Wellness. What we have now, to just sort of set a context, any kind of adverse event typically overlaps. And the ACE study, the Adverse Childhood Experiences Study, is from the CDC in the U.S. and Kaiser Permanente. And they have 10 adverse events that they test. And there's some sort of a lot of work available on the website, the ACE's website, and it shows that there are cutoffs of like 3 or 4 where we can predict significant physical health in adulthood from what they've experienced in childhood. This table that you're looking at asked adolescents what were adverse events in their lives, and they did talk about, so what you have in the first column is what the youth actually endorsed, and then in the second column it's the existing adult developed ACE events. So youth did talk about community stress, in fact, primarily, and neighborhood, things happening in the neighborhood that was negative. So we do see from the youth perspective that community resilience is very important. And having a reduced exposure to violence and increased exposure to resilience factors like having green space available to access. And research has shown that even if you see green space as a visual, that you have better decision making than if you were to look at a visual of a concrete building. So in your own personal art and resilience, having those kinds of positive nature visuals is going to be helpful and puts you in sort of more of a resilience frame. And in fact, when they've done research with what are the universally most liked painting type, across countries around the world, people will choose a landscape that is in fact evolutionary positive. So it's a landscape that shows hills, so you have and trees, so you have a point of better advantage for visually to what's going on in your surroundings, and a lake and a blue sky. So that is a universally most liked art piece. Going back to what the youth are saying then, after we look at the community factors, the youth are really talking about things like adversities that they would experience primarily in the home, like child abuse and financial hardship. I think that it's also interesting to note from the youth's perspective that they, we forget to take sometimes the youth's perspective, and family members, for instance, who may be experiencing mental health issues or substance use, kind of think of it more, or even asthma or chronic pain issues, kind of think of it more as their issue, and because of course naturally it's affecting them, but kids see that and they're quite impacted by the visuals of family members struggling. And teens are directly saying that this sense of felt sense of safety, security, and love is incredibly important for them. So we see in how youth respond to what are adverse events. We have the combination of, a distinct direct personal event like child abuse and community events like unsafe neighborhoods, etc. And the resilience is really the same, the combination of inner resourcefulness and inner resources with external resources, these community and in the home, in sort of the social ecology of resilience. So when we switch into a particular type of adverse event, child abuse and neglect, for the practitioner, you have the duty to report, and at the same time, you have the professional role to be, having a good working relationship. And practitioners often find those two things are quite challenging to maintain those twin goals. So it is a difficult area. And we do have, out of our hospital-based child abuse specialty clinic here at McMaster University, the CAP program, we have some articles in child abuse and neglect talking about a more positive approach that can help to maintain the relationship while child welfare is also involved in doing their part of investigating, having us doing our part of reporting reasonable suspicions. It's not our job to determine whether abuse has occurred or not occurred. And interestingly, and I'm going to tell you a shocking statistic from U.S. law enforcement, child sexual abuse is, from the Canadian perspective, the one area of child abuse where the police and the child welfare are cooperating and doing a joint investigation. So the police are most involved when child welfare is seeing a child sexual abuse case. And from the U.S. crime statistics, they have a much richer, bigger data set to help us understand what's going on. And for adolescent females who are, at least as the current statistics show, more likely to be sexually abused than males, although that is now, the disclosure is obviously a big part of that, and we're looking into that in our team grant. The female age is mid-adolescent, and the perpetrators are males. And for males, though, the perpetrators are dominantly males, And the age is actually 4 years old. But that's the modal age for investigations. And so I know that's a big shock. It was surprising to me because we're really asking quite challenging things of young people who are transitioning to school and who are developing language, these males, what's happening to these young males. And, you know, we understand the lower rates of disclosure if that's the modal age. And in our own research within the team, for instance, the MAP study, the Maltreatment Adolescent Pathway Study, when we looked at the caseworker reports of what they know to be true about the case and then what the youth are telling us, there was the lowest concordance for males. So only in 5% of the males endorsing child sexual abuse was the caseworker reporting that, yes, sexual abuse was substantiated or even determined as a potential or at risk. So I think that professionally we have a long ways to go in how we can support males to disclose their child sexual abuse and their traumatic experiences. With traumatic experiences, you may or may not have traumatic reactions. You know, child abuse covers a wide range, and sometimes you have asymptomatic victims. And more symptomatic will be, of course, with more severe maltreatment, more intrusive maltreatment, when violence was used, etc. And yet, even in those circumstances, you know, kids are can energize and galvanize their resilience. They can connect with a mentor, whether that's in school or if the maltreatment has been detected with their child welfare worker. Some of the main kinds of resilience factors will be around these attachment kind of relations that they can establish where they have practice in a new way of relating. And what this can be conceptualized as a resilience journey where the child and youth are able to take their own self-writing tendencies and connect that to resources in the environment such that they have some support to navigate and negotiate the available resources. And it will be the attachment relationship that will help them feel like these resources are safe and accessible and are created for them to use. So in a TEDx Hamilton talk that I've given that should be available broadly in the near future, these were the 7 steps that I talked about as the resilience journey. And the first step is really acknowledging the adversity. If you don't have that capacity to be able to say what happened to you, then it'll be more challenging to energize all of the potential resilience routes. Crafting a daily practice is talking about that resilience is work on a day-to-day basis. Like you, and even whether we've had or had not these adverse experiences, this is something that we really do have to energize and work on. Whether that's as simple as taking 3 deep breaths at some point in the day, or connecting to your Fitbit that tells you to stand up now and move around, that it is a daily practice to manage your resilience. Just like for youth, especially, sleep is one of the daily resilience practices, adequate amount of sleep. We know generally youth don't get adequate sleep. And from our MAP research, we know that youth have, 60% of the youth in that study endorsed that they had sleep onset problems. So developing sleep hygiene, which we know to be evidence-based practice, and having calming routines to ease into sleep are really fairly easy to implement. They're evidence-based and they're very strong resilience practices that will carry the youth forward in time across their development. Shifting perspectives and mindsets really talks about having that kind of growth mindset and self-compassion mindset where you see mistakes as part of learning and they are signs to you as to what to do next time, and that you see yourself in a bigger perspective, so you're not overly self-focused, that you understand, kids or youth in general are having challenges, and that development carries you forward. There's reason for optimism, and that it's about the effort that you can apply and then reflect on in a day-to-day basis. So it's really switching from a reflexive mode to a reflective mode. And of course, adolescent development, you have increased capacities in abstract thinking, so that is a well-timed intervention. Reaching out for help, seeing reaching out as not an index of weakness. So often people are feeling that to identify a mental health concern is a sign of personal weakness or failures, when reaching out is really resilience, that the help is there for you and there are good helpers out there. That's sort of a process that will help in this resilience journey. And you may not need help all the time, but not to let yourself sink when there is help. Like Kids Helpline is 24 hours and it's anonymous, so there's all sorts of help that covers your 24 hours. Transforming burden into beauty is really moving along towards a mastery of your adverse events, and this really talks about that the strength that you can energize out of what you've experienced, the greater interpersonal sensitivity that you can energize from your experience, and the advocacy roles that you can move into are really transforming your burden into something beautiful, productive, an offering to others. Managing your stress storms is to be anticipatory that stress is a part of everyday life, and to have your, it links back to your daily practices, when you're starting to feel stressed, to know what those feelings and how that maps in your body. And one example of an activity you might do with kids is a coloring in a body around where do you feel your anger, where do you feel your stress, and where do you feel you're happy, where's your happy place. And so just having that sense of where it sits or comes up in the body, and that is a cue to sort of take a moment, take a few deep breaths, drink a glass of cold water, interrupt that stress escalation process with some simple resilience routines. And just hoping that people are seeing the key messages that resilience practices can be very simple, very brief, and very easy to implement. And youth do like to use music. Music is, music and the arts are very available and welcome resilience because there's no really right or wrong in them. In the art world, the greatest value is that what you get out of it is absolutely correct for you, and there's no specific right thing to get, and that's why it's sort of expands the parameters and increases people's perceptibilities. And emerging and extending your grace is really just that place where you've come to where you can then provide offerings to your children. So it's part of like interrupting the intergenerational cycle of maltreatment, for instance. That's about at around 30% of parents. So this is sort of just a frame of a kind of understanding that there is a way through, and these are some steps that can happen in parallel. They're listed sequentially, but can sort of, once you have a vision, it comes back to the art world. If you have a vision for it, then you can paint it. And if you have a vision of wellness, then you can, map out like a storyboard what that would be. And that is perhaps a useful exercise. And this is going just back to sort of looking at some of the information, again, that when we look at child abuse-related fatalities, the data across various countries seems to lie in males being more likely to be subject to these child abuse fatalities at about, say, 60%. So that, and the primary perpetrators are males. So you might raise a question around why are male children being killed in child abuse context by male adults, and this is either the biological parent or the partner of the mom. So just taking these tragic events and trying to learn something from it, and again, a kind of shocking statistic is that 1 in 6 of these children who died had a prior disability or chronic illness, and that when children are born and have, even something that is as common as colic, that we need to provide special attention, monitoring, and support for parents to expect sort of that they're going to feel frustrated and it's going to feel aversive, and then what are the safety strategies? Can they put the child safely in a crib and allow that to happen? So it's really their reaction, the parental reaction to the child as aversive, that is the problem, and therefore that's the target. When we want to understand a bit about the statistics, there is a UK report from the Child's Commissioners that came out in fall of last year, and it has a lot of information about the disclosure process and how many times kids have to tell before they're heard, and what are some of the mental health issues. We know mental health issues are typically in one or more of the domains of aggression, depression, somaticization, and self-harm, and that can include suicidality and substance abuse. These are sort of the typical mental health expressions of trying to adapt to a really unadaptable situation, so that, again, we come back to reporting being an important and potential resilience intervention in and of itself, to bring in early intervention and to help prevent re-victimization. And we know that earlier disclosures predict better health outcomes, and that circle diagram is just showing that, wow, those youth, if we think back to the slide where they talk about what's going on and saying that the stresses come from in the home or in the environment, that in Ontario anyway, nearly half of the child welfare cases have exposure to intimate partner violence. So that we really need to think through what the full experience of children are in families, and that exposure is very unsettling. Of course it is to a young child to see, for instance, their mother being hit or shaken. Of course that's their attachment figure, and attachment research shows that there's no such thing as a kid not being attached. The kids are always attached. They may be attached insecurely. Their attachment may be very disorganized. They don't know what to do in the environment. They either approach or avoid, or approach avoid at the same time, and kind of freeze and still. So that we really need to have those opportunities for resilience. And again, the ACE research has shown that if a youth has 3 or more people to talk to, that's a strong buffer for these negative events. Because really another resilience factor is the sense of mattering, that you matter to other people, and that you are important, and that's so critical, is to convey that sense of mattering to a child or adolescent. And as again, it just echoes the theme, is that their disclosing is a hard task to have adults to really hear things. And there's some things that are just nonverbal, but you have a sense that it's bizarre, and one would need to sort of follow up that. But at the same time, they're kind of ambiguous, so there's maybe a tendency to do what's called gaze aversion. So, just not really attend to it. And an example would be, for instance, if, a boy in junior kindergarten grade 1 was very aggressive, and he's tagged for his aggressiveness, but when he's in the lineup, he pokes the child in front of them with a pencil. That's a problem, and something that should be followed up if there are any kind of attacks to sexual areas, or areas where we know kids would get abused in. And it does seem like it takes a lot, so that if you have 3 types of substantiated maltreatment, physical, sexual, or witnessing violence, and this comes from work of Dr. Harriet McMillan and Tracy Afifi, you would have a 16-fold increase in likelihood of being picked up by CAS, or Child Welfare or Child Protective Services. So it shouldn't take that much abuse for a child to be recognized as a victim of violence. And people may be familiar with the Canadian Incident Study, and it echoes the circle I showed you before around Ontario's experience. Again, exposure to intimate partner violence is a huge issue nationally, and some of the maltreatment, especially neglect, is chronic. But just because it's chronic doesn't mean we don't keep trying to put the external resources in place to create a better developmental environment. And we know that healthcare professionals are among the lowest reporters to child welfare. Educators are among the highest reporters. However, when the healthcare provider does report, it's more likely to be substantiated than the educator reported maltreatment. So it's very much a priority, and it fits with the CanMed's roles that you have that professional, expert health advocate, communicator, collaborator around the child's best interests and when there are violence issues at hand. And this just talks about what I mentioned earlier around the high prevalence of the same types of sexual abuse in the male youth, and the MAP study had child welfare involved youth. So all these youth were receiving services. And again, disclosure is a process, so perhaps it's in adolescence that they're able to better fill out a checklist kind of form on the behaviors that they experiences. And we have to really reflect on, do we as professionals, have we obtained adequate enough training to have this professional resilience, because we really deserve to be feeling professionally resilient about it. And that's just for those who aren't familiar with CanMed's roles, the diagram for that. And now we're going to switch into the art aspects of how art can help us with detecting child maltreatment and perhaps enhancing our mandatory reporting comfort levels. So we'll go to the video.
There's a prevailing attitude that art doesn't matter in the real world. But the study of art can enhance our perception and our ability to translate to others what we see. Those skills are useful. Those skills can save lives. Doctors, nurses, and law enforcement agents can use painting, sculpture, and photography as tools to improve their visual acuity and communication skills, which are critical during investigations and emergencies. If you're treating an injury, investigating a crime scene, or trying to describe either of those things to a colleague, art can make you better at it. Here, imagine you're a seasoned cop or a dedicated doctor, but also imagine you're at a museum, and let's look at a painting. René Magritte's Time Transfixed of 1938 depicts a mysterious and complex interior that invites analysis not unlike that required of a patient's symptoms or the scene of a crime. A miniature train, whose origin and destination are unknown, is emerging from a fireplace, and the smoke from the locomotive appears to flow up the chimney as if from the fire that is conspicuously absent below. The eeriness of the scene is echoed in the empty living room, enhanced by wood grain floors and decorative wall moldings to the right of the fireplace. Perched atop the mantelpiece are 2 candlesticks and a clock. Behind these objects is a large mirror that reveals an empty interior and only a partial reflection of the objects before it. The juxtaposition of the objects surrounding the moving train raises numerous questions for which there seem to be no apparent answers. Did I summarize the painting accurately or leave any details out? It's no big deal if you see something else in a painting. But what if we're both seasoned cops? I call you for backup, you show up, only to realize the 2 bank-robbing ninjas I'd mentioned were actually 6 bank-robbing ninjas with lasers. Close study of art can train viewers to study thoroughly, analyze the elements observed, articulate them succinctly, and formulate questions to address the seeming inconsistencies. Scrutinizing the details of an unfamiliar scene, in this case the work of art, and accurately conveying any observable contradictions is a critically important skill for both people who look at X-rays and those who interrogate suspects. Let's interrogate this painting, shall we? Okay, Margriet, that's quite a little picture you've painted. But why aren't there any train tracks? Why no fire? What happened to the candles? Why doesn't the fireplace have a little tunnel for the train? It just comes straight through the wall. And the clock says it's about 1:45. But I'm not sure the light that comes through the window at an angle says it's just past noontime. What's this painting all about anyway? That's when you, my trusty partner, hold me back, then I leave. You get Margriet a cup of coffee and keep grilling him to see if this painting would hold up in court. Viewers can provide a more detailed and accurate description of a situation by articulating what is seen and what is not seen. This is particularly important in medicine. If an illness is evidenced by 3 symptoms and only 2 are present in a patient, a medical professional must explicitly state the absence of that 3rd symptom, signifying that the patient may not have the condition suspected. Articulating the absence of a specific detail or behavior, known as the pertinent negative, is as critical as stating the details and behaviors that are present in order to treat the patient. And conspicuous absences are only conspicuous to eyes trained to look for them. Art teaches professionals across a wide spectrum of fields not only how to ask more effective questions about what cannot be readily answered, but also, and more importantly, how to analyze complex real-world situations from a new and different perspective, ultimately solving difficult problems. Intense attention to detail, the ability to take a step back and look differently. We want first responders to have the analytical skills of master art historians at least. Art trains us to investigate, and that's a real-world skill if there ever was one.
Again, and I hope you enjoyed that bit on how art really can make a practical difference in our approach. So we're just having a little bit of escape. And
you just have to click on the slide there, Chris. Just click where your mouse is there.
Click where your mouse is on the slide.
Yeah, now it should have done.
Okay, we're good. And here we are. The value of an art-based system is because we all just assume professionally that you're going to pick up observational skills rather than directly teaching it. And the art approach, formal art analysis, provides you with a system of looking, and this turns out to be very useful as it relates to child abuse injuries. So you look at the color, have in mind to look at the color, the texture, the shape or form, the space, where there's emphasis and pattern and repetition. So what the research has shown on visual literacy is that it has improved in a number of areas, and this is still a developing area of research, and in part it's how you measure it. And we, in our course, we provided a course on this topic, and we've measured the perceptual accuracy. The figure in terms of how formal art analysis progresses you first transcribe it or describe it. In our course, we asked the learners to describe what they were seeing along those lines of color, shape, form, which helps you not to jump to any kind of interpretations, that you just describe what you see, and that you then look at the connection, because if you have, for instance, an injury on the buttocks area, then if you start to look for shape in particular, you might start to see that as a handprint, knowing that the red areas will be in between the fingers. When an undergraduate medical student might have the opportunity to see that, we have to remember that they, like some new parents, won't have experience with kids and won't necessarily connect to that. But that sort of is the way that we move through, is to look at those visuals and to connect them. And we know rules in child abuse that certain places are where we'd expect bruises, and if an infant doesn't cruise, they shouldn't be bruising unless they have other disorders. And we always just keep in mind child maltreatment as a rule out in case presentations. So when we look at this visual, we might talk about where does our eye go to first, and then it's an evidence-based approach that you have to articulate what is your data for saying that. So you may say, in fact, that your eye goes first to the infant in the swirl, and the data is because perhaps that is the area that has the most white or lighter space, that has the most highlighted areas, so it draws your eye there first. And just like in injuries in child abuse, it might be redness. In x-rays, it might be, greater areas of white that we're seeing. So when we look at this picture, it's well known. Our eye goes first to the mother, who is located centrally in the pictures, and her arm, in fact, vertically goes up to her face, and that draws our eye into the center. So we can talk about the evidence around the whys, and this PowerPoint will be available for people to look at post. This is from a published case report from the CAP, the McMaster University Team, and here you have a burn injury, and as you go and look, you may notice to the left a bruise and discoloration, and then to the right it widens. So we can, and at the knee there's an injury, and so we can definitely say, if we take the art analysis approach, that this has a definite shape to it. And having that awareness leads us to think a bit more about, well, what possibly could have caused this, and then we go back to the social history taking to learn what has gone on. And what went on here was an infant clothed, sitting in a plastic car seat for 4 hours on a sunny day. And the plastic, with direct sunlight, heats up to a very high degree. One outcome of this case report was that public health issued a warning about how hot car seats can get. And in this particular case, when they brought the car seat in, you could see this match of the shape to the fact that the fabric was off on the one side of the seat. So there wasn't a pattern in the sense of both legs were symmetrically burned in this way. What the outcome was, the appropriate call to Child Protective Services and Ontario CAS, because the parent didn't know how this burn happened. So that is an appropriate call to child welfare. And then because when a story doesn't make sense, or there's no story for the mechanism of injury, and that's a signal that it's an appropriate call. And then as the evaluation continued, the car seat was brought in, etc., it was determined that it was an accidental burn. The art approach that we'll be presenting in more detail in the Picturing Wellness Conference really kind of looks at both what is there and what is missing. And if I've asked you to look at shapes of birds, then you'll see the colorful birds. What is there that birds don't typically have are these spheres that are attached to the birds. What is not there are these outlines of birds that seem to be either birds that were or spirit birds. We're not really sure, but we can say that we see them. And so that is part of the thing with the art approach, is to train your eye around what you see that should be there, that shouldn't be there, and what is missing that should have been present. And for further resources, as you saw, we profiled some TED-Ed lesson. We ourselves have created 2 TED-Ed lessons that you can go on, and they're organized to be evidence-based and high interest, as well as you can go on to my Prezi presentations. There's some on child sexual abuse, there's one on art and education, and there's one on mandatory reporting. And if you follow the hashtag on Twitter on Picturing Wellness, then you'll also get to information. So thank you very much for your attention, and we'll go back to Doug.
All right, thanks, Chris. And we're just going to do one more poll here. And in fact, it's the exact same question as we asked before. When picturing wellness, what has the greatest impact? And the 4 choices are the same. And we just want to see if anyone's impression changes, if their answer changes over the course of this presentation. So the answer choices are social ties, inner grit, a combination of inner and external resources, physical practices, for example, yoga, or other practices such as that. All right, we'll close this off. So we're going to look at the answers from the first poll, and we had 83% said a combination of inner and external resources, and 17% said social ties. And then following the presentation, we had a few more people came over to the combination answer, but pretty close. Still 86% said a combination and 14% said social ties. So not too much change over the course of the presentation.
Yeah, and that's really reflecting perhaps a sense of how important the attachment relationships and the social, that is in fact social ties the most important sort of resilience factor. But in terms of the optimal way in which we would picture wellness is that combination of inner resources and external resources. So the capacity for relating and self-writing connected to those social ties. So congratulations on your responding, and thank you again for your attention. And I think we have 5 minutes or so for questions.
Yeah, so that's our chance to just remind the audience to type in your questions into the question box. It's at the bottom of the control panel that's on the right-hand side of your screen. We don't have any questions right now, so we'll give everyone a chance. You mentioned, Dr. Weckley, you were talking about the conference, or actually Margaret, I think, was talking about the conference and everything that you're hosting coming up in a few weeks. Are there other examples at that conference about, that was a great example of the car seat, the child that presents to an emergency room and that sort of thing. Are there other examples of where healthcare practitioners can use this methodology in other parts of the hospital? So, for example, in the intensive care unit or other areas of the hospital, not just in those sort of emergency traumatic injury kinds of situations. Do you have other examples of how this can be used?
Sure. As part of the conference, we'll go and do a group viewing of the Picturing Wellness art exhibit, and you'll see sort of the different pieces and what are the themes there that can be picked up and utilized in the art that's shown in a hospital, for instance, or in examining rooms where people will be looking up, that you put a poster on the ceiling to calm an anxious child, adolescent, or adult. And one of the examples would be a painting of a bird. So the bird's in a really pleasant color, and it's emerging from darkness, and that sort of gives an uplifting sense, and uplifting quite literally as the bird is flying up So these kinds of examples can be seen in the conference, and we'll have a discussion from the developmental pediatricians and the child abuse specialists who selected art from the 5,000 plus pieces at the McMaster Museum of Art, and sort of why they've selected them and how they see the resilience there.
All right, so we've got a fairly quiet audience today. It was a fairly small audience, and I think given the nature of the topic, I think it was difficult to describe how relevant this would be to the average healthcare practitioner in a hospital or community setting for that matter. So we did have a fairly small audience for this one. So I do hope people do take an opportunity to share this with their colleagues, because I think this is such a useful tool that it helps people sort of think outside the box and get rid of some of those biases that they might have when they are looking at things, or other ways that they can use visual imagery to help their patients, their children and adolescents that they're taking care of.
Yeah, absolutely. There's a sort of sense of to put yourself in this, science box and think therefore art has nothing to do with you. But to understand the science of resilience is also to understand the science in art, and the art in the science of the art in the practice. We're all familiar with when a kid comes into emerge that you're making the decision right away whether this is a really sick kid, and so that's based on often your visuals of the child. So it is an innovation in the translation of evidence-based knowledge, and so we encourage others to share this talk and to invite a consideration. I mean, ultimately, the most accurate scientific perspective is one that is open to all possibilities and open to the evidence on that. So being open to sort of how art can enhance resilience is, I would say, a feature of a good scientist.
All right, so we are pretty much out of time. Is there any final comments, closing comments that you'd like to sign off with, and maybe reminding people the dates and locations and where they can find more information about the conference and the art exhibit?
Right, so the conference is at picturingwellness.ca, has a website. The dates are March 3rd, 4th, and 5th, so coming up. And the early bird registration for those who like to save some money is closing, though, at the end of January. So we welcome folks and to come over to Hamilton and meet us in person, and we'd be delighted to chat some more about these issues.
All right. Well, thank you, Dr. Weckerly, and thank you to Mark for joining us a bit earlier in the presentation. It was, I think we'll wrap it up now, and so thanks for a great, interesting and innovative tool that hopefully we can spread the word on and get some more people to be more engaged with.
Okay, thank you so much to everyone who's joined. Thank you to CAPC, Doug, and Ann, and on behalf of Margaret, we've really enjoyed this chance to chat and look forward to future opportunities.
All right. Well, thank you. All right. Just to remind everyone, we do our webinars every Wednesday at 11 a.m. Eastern Time, and it is always great when you can watch live, as there is an opportunity to sort of participate in the discussion if you want. But when you can't watch live, we do record these sessions and make them available after the fact on our Knowledge Exchange Network at ken.cafc.org. This Friday, we do have our monthly patient safety collaborative webinar at 11 a.m. Eastern Time on Friday. The title is Finding the Patient in Patient Safety Culture, and we'll be bringing Dr. Mark Fleming to join us from St. Mary's University in Halifax, Nova Scotia, to help us understand, review, discuss, and improve the promotion and development of a strong patient safety culture. And then next week on our usual Wednesday CAPC Presents, we will be welcoming back Dr. Christine Chambers to talk about the It Doesn't Have to Hurt campaign and creating a science media partnership. And joining Christine will be Erica M., the award-winning online publisher of the YummyMummyClub.ca, who has joined in partnership with Christine to create this initiative that aims to showcase strategies that are aimed to close what is often a 17-year gap of translating evidence into clinical care. And this initiative aims to increase parent uptake and application of evidence-based knowledge on children's pain through a partnership between health researchers and publishers. And yes, this is going to be a great opportunity to sort of talk about what they're doing with children's pain, but also talk about how we can use the strategies that they've been so successful at in translating other types of evidence and really closing that 17-year gap so we can get evidence into practice much more quickly. So some great stuff coming up in the next couple weeks. So thanks for joining us today, and we hope to see you here either on Friday or back here next Wednesday.